fetal erythropoiesis. When you talk about blood, basically fetal erythropoiesis means where is blood made from before birth. So think of a baby moving houses while growing. The first house is the yolk sac. So from the third to eighth week, the yolk sac is the region or area where the first primitive RBCs are made. So you can think about young is from Y and yolk sac is from Y. Then we have the liver, right? So the liver is the second house. This is from 6 weeks to after till the birth period. This is the main fetal blood factory. It produces most fetal RBCs. The young liver synthesizes blood. So Y is for yolk sac, and L is for liver, synthesizes the S is for spleen, and the B of blood is for bone marrow. So liver is from 6 weeks all the way till birth. And then we have house number three, which is the spleen. This is from 10 to 28 weeks, and this is more of a temporary helper. So the spleen acts as a temporary helper to the liver. And then we have the house four, which is the bone marrow. Now the bone marrow is basically 18 weeks all the way up to the adulthood. So this is the area or the house four, which eventually becomes the permanent factory. So a pathology question might ask you extramedullary hematopoiesis is seen in liver and spleen. Why? And the answer would be because liver and spleen remember their fetal role as blood forming organs. This is seen in conditions like myelofibrosis, in severe thalassemia, and in chronic hemolytic anemia. So, in diseases like myelofibrosis or severe thalassemia and chronic hemolytic anemia, why do you get hepatosplenomegaly? Hepatosplenomegaly is a very common symptom seen in these conditions. This is because the liver and spleen remember their fetal role as blood forming organs. And since there is a decreased number of RBCs in the blood. So, from somewhere, the RBCs have to be made to take over this role of decreased erythropoiesis. So, basically, the liver and spleen do that. Then we have the hemoglobin development. Okay. So, when we talk about the hemoglobin development, we talk about the embryonic globins. The embryonic globins are zeta and epsilon. Okay. In order to understand the hemoglobin, basically, you must go step by step. Okay, so the first thing is embryonic hemoglobin, right? So embryonic hemoglobin contains zeta and epsilon. And this is like a very early embryo only, right? That this is like the E embryonic hemoglobin. So this contains zeta and epsilon, right? The hemoglobin that is present in the embryonic hemoglobin is zeta and epsilon, but the hemoglobin present in a fetus is different. We call that HbF. Basically, we have two alpha globulins and two gamma globulins. So remember that the alpha will always stay, but the gamma will be later replaced by beta. So in a fetal hemoglobin and an adult hemoglobin, the only difference is that the gamma is replaced by the beta, right? So in an adult hemoglobin, you have the two alphas, but the gamma is replaced by the beta. Now, the golden rule you must remember is that the alpha is always there, but the gamma goes and beta becomes. So alpha is present in fetal life and adult life both. Now, why is hemoglobin HbF like the fetal hemoglobin special? Because the fetal hemoglobin binds oxygen more tightly. Why? Because the fetal hemoglobin binds poorly to 2,3 bisphosphogluconate. So 2,3 bisphosphogluconate means less, since it binds poorly to this, you have less binding to this molecule, right? So there's a higher oxygen affinity, so there's less 2,3-BPG binding. Now this leads to higher oxygen affinity. Since less HbF binds to 2,3-BPG, you have a higher oxygen affinity there. This pulls oxygen from the mother and delivers oxygen to the fetus. So this is basically really helpful for the fetus, for bringing oxygen to the fetus, right? Now, another thing you should see is that the hemoglobin switch occurs after birth. So before birth, the HbF is dominant, right? So you have two alphas and two gammas. This is dominant before birth. But after birth, the gamma decreases and the beta increases, right? So this gamma decreases and beta increases, and HbA becomes dominant. Now there's a sickle cell disease, right? So in sickle cell disease, what happens is in sickle cell disease, we use hydroxyurea. What does hydroxyurea basically does? It increases HbF. It increases the fetal hemoglobin. So more fetal hemoglobin means less sickling, right? So let's go back to our little image here and try to remember. So we said We said the yolk sac produces from 3 to 8 weeks. So you can see from 3 to 8 weeks the yolk sac is producing. And then the liver is from 6 weeks to after birth. And then the spleen is like this temporary helper which helps to form the RBCs from 10 to 28 weeks. And then from birth to all the way up to the adulthood, we have the bone marrow taking over. Yeah, now we have the percentage of total globin synthesis. Now, in the fetal stage, you can see that fetal hemoglobin has a lot of alpha and has a lot of gamma. In the embryonic globins, you have the zeta and epsilon here, right? So the embryonic globins are basically going up as you become part of the um, adulthood life. These embryonic globins are just here, right? This this is the epsilon and this is the zeta, right? So zeta and epsilon basically somehow finish up till the eighth week, and then you have this beta gene. So the beta gene is very low up till the birth, but then after birth, the beta goes really up, right? And this gamma goes really down, right? So that's how we can look at this percentage of total global synthesis, right? If you pause this and spend a minute here, you'll get what I'm saying. We now move on to the blood groups, right? So when we talk about the blood groups, talk about type A, B, AB, and O, right? So these are basically antigens. When we talk about blood groups, we talk about antigens and antibodies. So type A basically has an antigen which is type A basically has an antigen which is A, right? And the antibodies in plasma that a type A person will have are anti-B, right? So if it's an antigen A, it has anti-B antibodies. So if you give B group to a person who has an A group, the anti-B antibodies will cross-react with the B antigen, and you'll get this cytokine storm. Now, a patient with blood group A receives B blood. The result is acute hemolytic transfusion reaction because these anti-B antibodies will cross-react with the donor cells, right? And when you have the type B antigen, the antibody that is present is the antibody A. So if you give an A blood group to the B person, they're going to cross react, right? The antibodies of A are going to cross react with A. Now, AB is interesting. Now, AB has no antibodies, right? That's fun. So it has A and B antigens both, and it has no antibodies. Since it has no antibodies, we call it the universal recipient. Why do we call it universal recipient? Because it can take receive blood group from any source and not give you a reaction, and that's really cool, right? It's a universal RBC recipient. When we talk about O is the most difficult, guys. O has no antigens, but it has all the antibodies, right? That's a really big problem because O can receive, it can do, it is the RBC donor, right? It can give any blood. It can give blood to any donor, basically. It can become a donor, right? So it's the universal donor. I'm getting this all confused up. But what I want to say is that O can give blood to anyone. It can donate RBCs to anyone, and that's why we call it a universal donor. And it, Bichara, if it receives any non-O, you're going to get a hemolytic reaction. By the way, my dad and sister O, and that's just interesting that they can give blood to anyone, but they can't take blood from anyone other than O. And by the way, their personalities are very similar. So it's a fun fact for you guys. Now okay, so why something about this? Why AVO antibodies mostly IgM? Because exposure to gut bacteria creates them naturally. Exposure to all this gut bacteria creates these IgMs naturally. They do not cross the placenta, you can remember this. So these IgMs do not cross the placenta. But Rh antigens antibodies do, right? Because IgG crosses the placenta. So Rh is more important for us for when it comes to pregnant ladies, right? So when we study the Rh blood group, the main antigen is the D, right? So this D antigen is very important for us. If D is present, there are no antibodies present, right? And that's okay, right? So if it's Rh positive, that means that D is present. And if D is present, you have no antibodies present. Right now, important difference is that in ABO antibodies, the blood group antibodies have IgM, sorry. So IgM does not cross the placenta. This IgM does not cross the placenta. But this IgG crosses the placenta. This is why Rh disease occurs in pregnant ladies. So what happens is if the mother, if in the first pregnancy the mother is Rh negative, so the mother is does not have this D antigen, and the mother has all these anti-D antibodies, and the baby is Rh positive. So what happens during delivery? The baby's blood enters the mother, right? And now since the baby's blood has entered the mother develops these anti-D IgG antibodies, right? So there's no problem yet. This does not happen in the first pregnancy. In the first pregnancy, the mother does not have the anti-D antibodies. But when the Rh negative mother has this Rh positive baby, during delivery, when the blood enters the mother, that's when the mother gets these anti-D antibodies. Now, in the second pregnancy, the problem is the mother already has these anti-D IgGs. And now this IgG crosses the placenta, destroys the fetal RBCs, and hemolysis occurs. This is a very dangerous condition, and we call this hydrops fetalis, right? So you get severe fetal edema, jaundice, and kernicterus. Kernicterus is when bilirubin enters the brain, right? So you have hydrops fetalis, which is severe fetal edema, you have jaundice and kernicterus, and the bilirubin basically enters the brain. A clinical vignette would be something like an Rh negative woman, which is who is delivering an Rh positive baby, and in next pregnancy, the ultrasound shows fetal edema. The diagnosis would basically be hemolytic disease of newborn, right? How do we prevent this from happening? We give these patients a ROGAM. ROGAM is basically, so this is the hemolytic anemia disease of newborn. Now, prevention is by ROGAM. This is an anti-D IgG. It's given within 72 hours after delivery. So it's given at 28 weeks. Let me punch this here for you guys. So the prevention is done by ROGAM. This is an anti-D IgG. It's given at 28 weeks within 72 hours after delivery. Mechanism is that it destroys fetal Rh positive cells before the mother recognizes them. Right? So that's something we do to prevent this from happening to the next pregnancy. Then we also have an ABO, hemolytic disease of the newborn. That's when the mother is, let me go there. So we've talked about this, right? We've talked about the Rh hemolytic disease of the newborn. It's the Rh mother is negative Rh negative mother and the Rh positive fetus. Where pregnancy mother is exposed to fetal blood after during delivery, formation of maternal IDD IgG. In the subsequent next pregnancies, the anti-D IgG crosses the placenta, attacks the fetal RBCs, hemolysis is present in the fetus. You get hydroxytolis, which is extreme edema. Jaundice shortly after birth because the RBCs are dying, bilirubin is increasing. And then kernicterus, right? I told you kernicterus was when the bilirubin enters the brain. And then treatment, you prevent this by giving an anti-D IgG to Rh negative pregnant women during third trimester, 28 weeks, and early postpartum period if fetus is Rh positive. This prevents maternal anti-D IgG production, so the next pregnancy is safe. Now we have the ABO, hemolytic disease of the newborn. What happens is that in the ABO, hemolytic disease of the newborn, the type O mother has either a type A or B fetus. Now, pre-existing maternal anti-A or anti-B IgGs antibodies cross placenta. Hemolysis is present in the fetus, and this causes mild jaundice in the neonate within 24 hours of the birth. Unlike Rh, hemolytic disease of newborn, it can occur in firstborn babies and is usually less severe. Treatment is phototherapy or exchange transfusion. So basically, the mother is O and the baby is A or B. The mother already has IgG anti-A or IgG anti-B, right? So these all cross the placenta. Right, difference from Rh diseases for the ABO, the first baby is affected. It can affect pregnancy. It's very mild, but it's common. For the RH, usually the first baby is not affected. It can affect the pregnancy. Yes, it does. It's very severe and it's less common, right? So for the type O mother, type A newborn, there's mild jaundice within 24 hours. You get the APO incompatibility as the diagnosis. I'll stop the video here.